So I would like to thank everybody for coming. We're very pleased with the turnout and the opportunity to tell you a little bit about what's going on at OrthoCarolina Spine Center this evening. We've selected a few of us at the Spine Center to talk tonight. There's a plan for several more of these forums in which the rest of us will have the opportunity to speak. My name, for the record, is Alden Milam. I'm one of the spine surgeons at OrthoCarolina. I've been there since 2003. The Spine Center, as a facility, we're celebrating our 25th anniversary this year. It's a 20,000 square foot freestanding facility. It is dedicated only to spine conditions. We are fortunate enough to have an MRI unit, arthrograms, a spinal injection suite, as well as office space in our facility. We perform over 2,000 spine surgeries every year and about 4,000 interventional spine procedures every year. We've been fairly prolific this past year in research. We've had 21 different abstracts and presentations accepted actually around the world, even down in South Africa and in Europe. We're the only regional spine center where every surgeon is spine fellowship trained and board certified. And we have improved our access over the last years with a walk-in urgent care clinic that occurs in nights and weekends. The OrthoCarolina Spine Center also hosts two different spine fellowship programs. One is a spine surgical program, which is the longest running and most comprehensive spine surgical program in the region. We also have a well-established physiatry fellowship program that is integrated with our monthly teaching conferences that we do. We are the teaching faculty for the orthopedic residency program, and each week we have multiple multidisciplinary conferences that we discuss complex cases and educate our colleagues as well as ourselves and try to stay up to date in clinical practice of spine surgery. We've been involved in a bunch of different societies. This list is small on purpose because you wouldn't recognize many of the names, but we've been fortunate to have the president of the Cervical Spine Research Society, which is one of our most prolific organizations in spine, the secretary for Lumbar Spine Research Society, members of the board of specialists in the academy, and also, I'm going to go through each of our providers in alphabetical order. So Bobby Alexander went to undergrad at NC State, did his medical school at UNC Chapel Hill, and then did his residency at Carolina's Medical Center, and then his physiatry fellowship up in Winston at Orthopedic Specialist of the Carolinas. Unfortunately, I don't think Dr. Alexander's here this evening. Dr. Chapman will be one of our panelists tonight. He went to Davidson in Georgetown, did his medical school at Wake Forest, residency at Duke, and then did a complex spine fellowship, a spine surgical fellowship at WashU with Larry Linke and Dan Rue. Bruce Darden also went to Davidson. You might see a theme in these slides with Davidson, and then went to med school at Chapel Hill, did his residency also at Carolina's Medical Center, and his fellowship at Baylor. Eric Laxer, our token Canadian, he went to Vanier for college and McGill for medical school and stayed there and did his residency at McGill, and actually did his first spine fellowship at McGill, and then came down across the border. We apparently didn't build the wall there yet, to sunny Buffalo. And then stayed and moved down here to Charlotte, so we're very thankful for that. Alicia Lazeski went to the Florida Institute of Technology for college, and then sunny upstate for medical school, and then she did her residency at Carolina's Medical Center. My name's Alden Milam, I went to Furman for undergrad. I went to Vanderbilt for med school. I was at Penn in Philadelphia for my residency, and I was at Case Western in Cleveland for my spine fellowship. Dr. Kinjal Parikh went to college at Loyola, Nova Southeastern for his medical school, then UT Southwestern for residency, and actually did his spine fellowship, his physiatry fellowship with us here at OrthoCarolina. Al, as I mentioned, the theme, if you go to Davidson, you can come become a spine surgeon at OrthoCarolina. So he did his undergrad at Davidson, Chapel Hill for med school, Wake Forest for his residency, and then at the University of Maryland at shock trauma for his spine fellowship. Brad Segabarth went to Kentucky both for undergrad and med school, then went to Vanderbilt for residency, and then we were fortunate enough to have him come to OrthoCarolina for his spine fellowship, and then he stayed with us. Leo Spector went to Colgate for undergrad, then UMass for med school and residency, and then came to OrthoCarolina for his spine fellowship and stayed with us. And then Ron Vandernoord went to the North Georgia Military College for undergrad, then Medical College of Georgia for medical school, University of Louisville for residency, and then Georgia Spine and Sports Physicians for his spine physiatry fellowship. Our first speaker is going to be Dr. Brad Segabarth. He's going to speak to us on minimally invasive fusions. And before I bring Dr. Segabarth, well, Dr. Segabarth can come on up to the mic, but I wanted to mention you have some white postcards with pencils at your seat. If, as questions arise, please write them down. You can give them to our volunteers who are going to be on each side of the aisle and collect those. And after we're done with the talks, I'll ask these questions that you presented to our panelists. So, Brad.
Thanks, Alton. So, thank everybody for coming out tonight. It's a great turnout. Hopefully, you guys will get something out of it. See some familiar faces. So, as Dr. Milan mentioned, I'm talking about minimally invasive fusion. So, MIS, or minimally invasive surgery, MIS is the term for it, by virtue causes less collateral tissue damage. It offers a decrease in morbidity and a more rapid functional recovery than traditional surgery. But we do this without compromising the surgical goals of traditional surgery. So I'll start with kind of a case of a patient of mine. This is a 68-year-old that has some degenerative changes, has some scoliosis, has some disc collapse, but complains just of some leg pain. So some left leg pain that's really preventing her from being able to walk for the last year as much as she wanted, and it's gotten worse over time. So I'll get back to this case after a little bit of the talk. We'll revisit it. So what's new with spine fusion? Well, there's something called lateral access or transpsoas surgery. And what this allows is for a different corridor to access the spine. So I don't have a laser pointer, but I'll try and point a little bit. The picture on the right shows that we can, through a 1 or 2 inch incision, can access the disc through a different channel. So rather than traditional surgery, when we go in the back of the spine and have to remove muscles and bones just to get to the area we want to retract nerves, you don't have to enter the canal, and so you can leave all those other structures left alone and undisrupted and access the disc from the side. You can put implants in, remove the disc, and do this through a very small working window. So this is kind of a depiction of the operating room, what we're looking at. We have to know where we're going without seeing it, so we use x-ray guidance. So the picture on the right shows you what we're looking at in the operating room, and we actually draw these lines and mark out where the disc space is and where the spine is on the skin. So it gives us a more targeted approach. And then we use small little dilators there, like the picture on the left, to help get us there. So this is an example of kind of what it looks like. We draw the lines on the skin, so this allows us a more targeted approach. And then this is what it looks like when we're in the operating room. This is what we're looking at. So here the surgeon is not just looking in the wound and at the patient, but we're spending about half of our time looking at x-ray guidance. It shows us things that we can't see when we're working through a small channel. So we're looking at x-rays, and if you see the picture on the right, our view is through that corridor, through that channel where the retractor is. So we can directly visualize the disc and do traditional open surgery through a smaller little incision. And this is what it looks like at the end. So small little incisions. And actually, this is an older picture. Now we're really down to one incision for this procedure rather than two. And so oftentimes we rather than just doing the disc surgery, we sometimes have to put screws in the back or other hardware, which we can also do through small incisions, little 1 centimeter incisions. I think Dr. Laxer is going to talk a little bit more about that. So the reason this works is based on this concept of indirect decompression. So if you look at the top picture there on the right, this is a degenerative disc. The disc is completely collapsed down, which narrows the space for the nerves in the channels. And so at some point, it meets its threshold and you get nerve pain. So traditional surgery is you go in the back of the spine and remove the bone, remove the ligament, stretch the nerves out of the way, and unpinch the channel, which is a way to directly visualize and do that. But if you could just access the disc, like the bottom picture, and restore that disc height back to where it was, then you provide a little more space for the nerve root, and then that may be enough to relieve the symptoms, and you leave the rest of the structures untouched. So it can also allow you, as I said, to put implants in there. It can help with fusion augmentation, so it gives you something to fuse in between those bones, and also can help with correction of some deformity. So I like to think of this more as a surgical strike rather than carpet bombing. So we'll go back to the case. This is a 68-year-old, 1 year of progressively worsening leg pain. So when you look at this X-ray, a lot of you can probably see it's not a straight spine. So this patient has scoliosis, and so she's very worried that, do I need a big surgery? I've been told at some point I had scoliosis and may need a big surgery to correct all this. But her complaint was more just nerve pain on one particular nerve. So as an orthopedic surgeon, I want to see what her scoliosis looks like, and is it balanced? Does it even need to be treated? So we get X-rays from the shoulders all the way down to the pelvis. And if you look at that picture on the left, the scoliosis, while it's there, it's very well balanced. So mechanically, I wouldn't anticipate this should be a problem, and it may not need to be fixed. And she lived with this for several years and didn't cause any problem. So we investigate a little further, and if we do MRIs and we try to diagnose this a little better, we can figure out that the bottom level, she's got a collapse of one disc, and the nerve is pinched at that bottom level on your right side, her left side. And so we try to target that with an injection, which some of our partners can do, and it took away all of her symptoms. So now we can think of this surgical strike. Maybe we can just do something at that one level and take care of her symptoms. So the operative plan was MIS, so minimally invasive surgery, for an indirect decompression, percutaneous or small little incisions to put screws in the back, and place an interbody graft where it's most tilted over to give that nerve root some more room. This is what it looks like in the surgery. So we put a spacer in there. You can see the little lines are the edges of the spacer, and it opened up that space. So you get the indirect decompression, the front views on the left and the side views there on the right. And then we put small incisions in the back and put the screws in through X-ray guidance as well. So this patient comes back for her first post-op visit at 2 weeks, and she asked me a question, is it okay if I go hiking? And I said, yeah, I think that would be good for you. And she said, well, good, because I walked 2 miles yesterday. And so you can really get back to pretty early, return to function after some of these approaches. So we didn't leave her alone at 2 weeks. We follow her out, and here we are at 4 years after surgery, because we wonder, well, she's got scoliosis. Did we disrupt that? Did we cause a problem doing a small fusion in the middle of this? Her curve's the same. It hasn't progressed. She has no back pain, no leg pain. So by doing that one level, it took care of her symptoms. So I have another case, but for time, I'll just kind of skip through this one. But it's the same idea. There's a focal deformity at the bottom level where the spine shifted off. And rather than do a large open procedure, we did the same type of procedure because this corrects all the way if she lays down on an MRI scan. So if that corrects, then it's if we could just lock her in that position and do a minimally invasive fusion, that's likely to be enough. So in conclusion, MIS is an option for specific conditions. It treats a focused problem with a focused solution, and it allows early return to life and activities, but it does not compromise the surgical outcomes or the goals. So, thank you.
Paul, can I get this one, Paul? Sorry. While our next speaker is coming up, I was going to ask Dr. Segabarth a quick question. So, Brad, you showed us some very interesting cases here with this lateral approach. Who do you think is the ideal patient for this transpsoas lateral approach?
That's a good question. With new techniques, there's always this tendency to try to apply it to everything, and that's just not the case. And so it's an extra tool in the bag in the arsenal that you can use for selective cases. The answer to that question really kind of gets back to what you're taught in med school and residency, and you got to talk to the patient and ask them some questions. And the most important question for me is, does your pain go away if you lay down? So if it goes away when you lay down, then that tells me there's something dynamic. So if we lay you down in the operating room, you're in that position where you don't have pain. So if we can lock it in that position, then that should be enough to take care of the symptoms. So you actually have to talk to the patient, figure it out, and I think that helps us to have the right treatment.
Awesome. Thank you, Brad. So our next speaker, you can hold the pause to the end, maybe. Sorry. So again, if you have any questions for Brad, or sorry, Dr. Segabarth, if you just write them down, those note cards, pass them to our volunteers, and then I'll read those out at the very end, and we can get those. Eric Laxer is one of our surgeons at the Spine Center, is going to talk to us about robotics and spine surgery.
Thank you, Dr. Milam. It's true, I am from Canada, and I remember when we were planning on moving down here, friends and family kept saying, do you realize how hot it is when you go down to the south? My answer was always, coming from Canada where there's a lot of snow, you don't have to shovel the heat. So I think when we moved down, we actually moved up. So I'm going to talk about robotics, which is a relatively hot topic in spine lately. And everybody knows that a robot is a device that automatically performs complicated and often repetitive tasks. And when you are a surgeon and you have the ability to improve your control, your precision, and your consistency of anything that you do, that's like the Holy Grail. That is the best way of increasing the chance of obtaining a consistently successful outcome every time you do a procedure. If we look at the history of robotics and spine, this is all relatively recent. In the 1990s, the medical robotics team at the Technion University in Israel did a lot of research in this area. In 2001, they founded the Meso Robotic Company. In 2004, the FDA approved Spine Assist, which was their first robotic spine platform. In 2011, they introduced their Renaissance guidance system. And in 2017, this past year, they introduced their latest system, which is called Mazor X. The application of robotics in spine surgery is specifically for pedicle screw insertion for spine fusions. In this context, the robot functions as a navigational unit. The robot also improves our capability of performing minimally invasive procedures along the lines of what Dr. Segabarth mentioned, and I'll touch upon that in a few minutes as well. So what is a pedicle screw? Basically, a pedicle screw is an anchoring point in an area of the bone in the spine called the pedicle. This technique has been around in various forms for about 50 years, and today is really the most common technique employed by surgeons working on the spine to achieve a fusion. While it has many advantages, there certainly are potential disadvantages in terms of risk. As you can see in the photograph, the pedicle screw sits in a very narrow area, very close to the spinal cord and the spinal nerves. Traditional surgery in spine has been what's called open surgery. In open surgery, you perform an incision, you retract the musculature, you expose the spine, you have access to the bony landmarks, which help you determine where you're going to insert your screw, where you start your screw, what your trajectory is, etc. But as we move more toward minimally invasive procedures, and you no longer have those bony landmarks, you have challenges that you have to overcome. Where do you start? How do you aim? How do you know where the screw ends up being placed? Other challenges that we run into have to do with patients' individual anatomy. The picture on the left shows a nice straight spine. The pedicles are those rounded structures that you see at each level. In this particular patient, this is like a surgeon's dream. Nice large pedicles, no specific complicating features. Whereas other patients have challenging anatomy. An example is the patient on the right. When the spine starts to twist, rotate, it completely changes the orientation of the pedicles, making screws much more difficult to insert. There have been studies that have been done through the years looking at the impact of introducing various forms of technology geared toward the insertion of pedicle screws. And regardless of what that technology is, one of the things that we've learned is as you introduce technology, the capability of the surgeon to put the pedicle screw in the correct place, the correct orientation, increases. And in 2010, there was a study looking at Mazor's first generation platform, and the success of inserting the screws was extremely high. Now, why is this important? Is a 98 or 99% success rate in inserting screws acceptable? Those are pretty good numbers. The problem, as I showed you earlier, is we're working in an area where the risk is very high. So, for example, this is a screw from a paper that was published in 2013 by a group out of Canada. No coincidence. And as you see, they described 9 patients who had complications following spine surgery related to the position of the pedicle screw. All these screws were inserted in what's called a freehand technique. And if you look at that image, you can see that that screw goes right through the spinal canal at the T5 or 5th thoracic vertebra. And the outcome of putting a screw there is really catastrophic, irreversible and catastrophic. So with all these things in mind, improvement in accuracy, precision, moving towards minimally invasive procedures, in 2014 we decided to pursue navigation technology. We looked at many different types of navigation that are out there, and we selected the Mazor Renaissance guidance system. And we performed our first case in July of 2015. Earlier this month, we completed our 263rd case. Basically, this is what it looks like. On the left, you can see a platform that houses the software. On the right, you can see the robot. It's actually very unassuming. It's very small. It's about the size of a tin can, but inside it's very powerful in terms of its technology. And here's the big benefit. Patients undergo a CT scan a week or so prior to the surgery. The CT scan gets loaded into their platform, and it gives us the ability to virtually take their screws and place them in any location we want to in the spine. We can control the depth, the trajectory, the screw diameter, the screw length. We can control the position of multiple screws, making it easier to then connect them together when you do the fusion. And as I said, it's incredibly powerful. In the middle of that image, you can see the spinal canal like I showed you on the earlier picture. Obviously, we want to keep the screws away from the spinal canal and the spinal nerves. So this is a short version of what it consists of. We basically build a platform over the patient while they're asleep. We then place the robot on top of the platform, and the software guides the robot to the exact location we want it to be at. Once it does that, because it's a robotic-assisted procedure, it gives us a trajectory, and through that trajectory, we can then drill and insert the screws. So this is just showing you the surgical technique. Basically, the surgeon still puts the screws in. It's hard to see on this image, but you can see a hand on a screwdriver, and behind that you can see the platform with the robot sitting on the platform. And we start at one area and we move to other areas. You know, when you first look at the robot, the current generation, like I said, it's not very impressive. This is the Mazor X, which was introduced in 2017. It has more of a traditional appearance and feel. It certainly looks a little bit more impressive, and there are features that have been added to it. and surgeons are slowly starting to introduce that into their practice. I'm just going to show you a couple of cases. This is a patient who presented with back and leg pain. The image on the left is a side view of an MRI scan. The patient is facing our left, and you could see at the second to last level, there's pinching of the spinal nerves, which is the white stripe in the middle. And the image on the right is an x-ray, which shows that the bones are shifting. Ideally, we want to treat patients without fusions. Many patients can be treated without fusions, but in scenarios when the spinal alignment changes, if you do surgery and don't do a fusion, unfortunately, the problem can worsen. So that was the case with this particular patient. We did a procedure very similar to what Dr. Segabarth showed. We put a spacer in between the bones, and then using the robot to help guide, we put in 4 screws and 2 rods. And this is a typical appearance of what it looks like. In the past, for most of these cases, we would make a midline incision, fairly aggressive dissection. What we can do today is through 4 small openings. They're each about 1 centimeter or so. We put a screw through each of them, and then we connect the rods. These patients usually go home the day after surgery, and I can tell you that we're moving towards patients going home the day of surgery. This is another patient who had previous surgery, did well initially. Years later, over time, their spine started collapsing and displacing. They developed back and leg pain again, and we felt the best treatment for them was a fusion. So you can see that this patient has 6 screws and 2 rods, and these were inserted using the robotic technology. On the left, you can see the side incision that we went in to put the spacers in, and on the right, you can see the 6 smaller incisions through which we put the screws and the rods. In the center, you can see the scar from the patient's previous surgery. The most interesting thing for me about using this new technology are patients who I see who had traditional surgery years ago, and then they have some of these newer procedures, who leave the hospital the next day, come in to see me 2 weeks post-op, and remark on the incredibly different experience that they've gone through. I would tell you, spine surgery from the patient's perspective is not easy. I don't want to portray this as such, but relatively speaking, the experience they have the second time around tends to be much, much easier. So just to date, we've done 263 cases. We've inserted 1,300 screws. One of our patients had to go back to surgery the day after the procedure to have a screw removed because it was causing irritation. And if you look at that in terms of a revision rate or how successful the procedure has become, it's very successful. So I think this is very exciting technology. I think this is here to stay. And I think we need to continue to strive, as good as things are, to keep making them better. Thank you.
So, Eric, I have a question from the audience. Has the robot ever failed or stopped during surgery? And if it did, what did you do?
So it hasn't stopped during surgery. I will tell you the process, while really exceptional, is not perfect. We've had problems occasionally with the robot. You run into 2 types of errors. One are technical or robotic errors, and the other are human errors. The analogy I would give you is doing this kind of work is like flying an aircraft. There are a lot of things that can go wrong. You have to really know how to troubleshoot. The occasions where we ran into problems, we often made a decision that we did not decide to put a particular screw in. And so we found a way to continue doing the same type of procedure, but without using the robot to put the screw in. We either left the screw out, or we brought in an X-ray machine and used that to help navigate and identify our pathways.
Yeah, and I would echo that. I mean, basically, this is an adjunct or an additional way for us to help protect our patients. It doesn't supplant or the training that we've already, gone through and learned how to put pedicle screws in open or using X-rays. Sorry, I'm going to give us a chance. I'll promise you all the white cards. I will make sure we answer all the questions at the end of this. Promise. So in order for us to keep moving along, next up is going to be Dr. Kinjal Parikh, who's one of our physiatrists. And one of the questions on the white cards is, what is a physiatrist? And I will let Dr. Parikh tell us a little bit about that, but I think that'll become a little bit more clear as he talks as well. Thanks, Kinjal.
Good evening, everyone. So, quick question. Who here knows someone or has personally had a spine injection? Can you raise your hand? So we see a lot of hands going up in the audience. And who here knows exactly what type they've had and for what reason it was done? So we see a less proportion, but still a lot of people know what's been done. So today we're going to talk a lot about spine injections and what we do and why we do them. So in answer to Dr. Milam's question, what is a physiatrist? A physiatrist is a non-surgical orthopedist. Specifically at the Spine Center, we focus on spinal disorders, and our goal is non-surgical treatment to help people improve quality of life, feel better, and also avoid surgery. So our goals for today are to talk about what we inject, why we inject, how we inject, and how we safely do it. So a quick history of spine injections. The first spine injection was done in the early 1900s. Initially, they would inject cocaine, actually, via the caudal approach. So basically, they would feel around in the lower part of the spine to an opening, and they would put a needle in and inject cocaine flushed with saline. Obviously, that doesn't sound safe, so it's no longer in practice. With the advent of steroid medication in the 40s and 50s, in 1952, steroids were used in the epidural space given their potent anti-inflammatory properties. In the 1960s and 70s, it became more of a mainstream treatment for low back pain. At that point in time, they were injecting blind, which means that they were using palpation, so feeling around, or using known anatomical landmarks as the basis of their source for injection. That takes us to the 1980s and 1990s. As technology advanced, we developed image guidance. And fluoroscopy is something we'll talk about with the next slide, but that's the tool we use to actually visualize the spine in live time so we can put a needle safely and accurately where it needs to go. Studies were done that showed that up to 38% of people, trained professionals who were doing blind procedures, compared to fluoroscopically, they were misplacing their injections. So it shows a big importance of why and how important image guidance is. After that, CT and MRI continued to evolve, so physicians themselves were able to better understand the different pain structures that could cause pain in the neck, mid-back, and low back. This machine is the fluoroscope. So all it is it's a fancy X-ray machine. It allows us to go 180 degrees in each angle, 45 degrees on a front and back angle. But that allows extreme angles to visualize the spine. When we look at X-rays, you see a one-dimensional plane. The spine looks flat. The spine, the surgeons can say more than I can, is truly not flat. It's three-dimensional. There are extreme angles you have to take, and the fluoroscope allows us to visualize those exact angles. So we'll briefly cause about just low back pain, neck pain, and why people have spine injections. The lifetime prevalence of spinal pain is 65 to 85%. Most common causes are degenerative disc disease, lumbar spinal stenosis, cervical spinal stenosis, facet joint pain, and sacroiliac joint pain. So degenerative disc disease, also known as a slip disc, sciatica are common terms we hear from patients all the time. But what happens is the disc degenerates, and it happens due to the nature of the disc. The disc is a soft structure. It's a shock absorber that lies between the bones. And with use and age, the discs do degenerate. And that happens to all of us, no matter who we are or how healthy we are. But if the discs degenerate and actually herniate and push onto a nerve, they can irritate the nerve, they can cause nerve damage, and that can cause resultant pain and weakness. Another very common condition is spinal stenosis. Spinal stenosis in the lower back specifically is classically seen with buttocks or leg pain, with or without back pain. What happens is you have compression of the spinal nerves in the spinal canal due to wear and tear on the spine that occurs with use and aging. So how do injections work? Let's get to the bottom of it. Inflammation is the main reason people feel pain. You have two types of inflammation. You have physical inflammation due to the disc itself pushing on the nerve, a bone spur pushing on the nerve, or just due to degenerative processes going on in that area. The second thing is chemical inflammation, and that's what injections really target. Chemical inflammation is enzymes and irritants released by the body in response to injury. So if the body realizes that something is going on that's not supposed to be going on, it sets off an inflammatory response which causes molecules to be released in the area, which can be painful. Next, let's talk about what we actually inject. The main thing we inject is steroid medication. Patients often say cortisone, so they ask me, is this a cortisone shot you're getting? Yes, it is. Cortisone is a blanket term that people use for steroid injections, but the main function of steroid medication is anti-inflammatory. It inhibits the body's natural response to injury and irritation. It does not shrink the disc herniation, but what it does is it reverses the inflammation. We use a lot of lidocaine. We superficially numb the skin. We also inject lidocaine deep with our injections to help increase blood flow and also to further reduce inflammation. Lastly, we inject contrast dye to help visualize placement, to make sure we're not in a blood vessel, to make sure we're getting the proper flow that we need to get to the targeted structure. The risks and benefits of injection. Main risks are bleeding, infection, nerve injury. Any injection in the body will have those risks. We mitigate those risks by using the techniques such as image guidance and fluoroscopy. We use a very sterile surgical prep. Even though we're just doing an injection, we prepare it as if you're having an operation on the back with the same kit and the same tools that our surgeons use for their procedures. In terms of nerve injury and paralysis, these things do not occur commonly in less than 1 in 500,000 patients, because we have trained professionals doing them the proper way using the proper guidelines. In terms of radiation exposure, a typical epidural injection will expose you to 40 seconds of radiation. And when you see us in the procedure room, you'll see me in a fancy lead suit with glasses on. I look like an astronaut half the time. But in general, the 40 seconds of exposure is comparable to flying in a jet plane for 3 hours, also comparable to driving in a car for 400 miles. So you're not getting exposed to that much radiation. In terms of the injection day, we do them typically in office. We have a state-of-the-art procedure suite in our spine center building with a newly designed recovery room that we've just opened. We also do them at a surgery center setting for cervical spine procedures, and we can also offer IV sedation at the surgery center. In terms of injections, the most common injection that we do is the epidural injection. The goal is to deliver steroid medication with the anesthetic by the irritated disc and nerve. This is the most modern technique, so we can actually target a specific nerve or a specific disc herniation. It's highly selective, and we use a very low volume of medication. And these are examples of transforaminal injections. So you can see, if you can see, I don't have a pointer on it, but you can see these are the nerves exiting the spine, and that's a needle going right next to the nerve, and that's an animation of it, and that's an actual picture of an injection. So that's what I see on my fluoroscopic monitor. The picture on the right shows a very specific injection. We're going at a 2-level fusion. So definition of fusion, it's fused solid. We're able to put the needle and thread it truly to get into a very narrow opening and go in a closed area and deliver medication to a targeted structure. The real question is, do they work? So there have been some major studies done that do show good efficacy of it. The best study that was done in 2000, it showed that 70% of patients who had active disc herniations were able to avoid surgery with steroid injections, compared to 33% of patients who had a sham injection of just lidocaine. 5 years later, 81% of those patients still were able to avoid surgery. In terms of do they last? Only 25% of patients who had resolution of pain for a month reported a recurrence within that 1 year. So that 1 month mark is the real marker to see if you're getting better or not. Typically, we follow up patients 2 to 3 weeks after just to make sure everything's going well. But we'll see them again, usually at the 4 to 6 week mark, to make sure they're getting sustained relief before we kind of say, call us when you need us, or we can make another determination. People who waited longer to have a procedure have a higher likelihood of a recurrence. Other things that can cause pain are facet joints. In the neck and back, we have facet joints that link the bones together. Up to 45% of people have facet joint pain. Diagnosis with this is clinical. It's not based on MRI or X-ray. This is a non-surgical treatment. The gold standard of diagnosis is to inject it. If we inject the facet joint and you get relief, that helps us know that that's the cause of the pain. And the facet joints degenerate as a result of the discs thinning and the joints just degenerating as a result of it. It also occurs in the neck with whiplash-type injuries when people have motor vehicle accidents. And this is a demonstration of facet joint injection, just with injection into the facet joint. Ablations are other procedures we do where we actually apply heat to the joints to burn the nerve that supplies the joint. This typically gives people 6 to 12 months of sustained relief of pain. We're also doing ablation procedures in the knee now for people who have severe knee osteoarthritis who are not surgical candidates, or also people who have had knee replacements and are still having ongoing pain. The last structure we'll talk about is the sacroiliac joint. It's a small joint that connects the spine to the pelvis. Diagnosis here is based upon history and examination. And gold standard, again, is injection. If we inject the joint and you feel better, we know that's the cause of it. And then we can modify treatment and physical therapy towards that and treat you appropriately. And that's a demonstration of the sacroiliac joint. People who have had fusions or hip replacements are quite subject to having SI joint pain due to the location of the SI joint because it stabilizes the spine and the pelvis. So take-home points. The real take-home point for all of us today is 87% of people really do improve with conservative care. So conservative care predominantly begins with medication, physical therapy, chiropractic care, yoga. Time is a big part of it. We don't want to rush into injections. We definitely don't want to rush into surgery. Safe non-surgical injections do exist that allow us to help avoid surgery, and for non-surgical conditions, they do help improve quality of life.
Thank you, Kinjal. So just kind of a question. So we've got all these injections that we can use. Back pain's a really common problem. How do you use the injections to determine what a patient's back pain is coming from?
And that's a great question. The term we use is pain generator. So with the advent of modern technology and imaging, we're able to visualize different structures such as the facet joint, the SI joint, the spinal canal, the spinal nerve, spinal discs. So MRI typically will diagnose disc herniations and spinal stenosis. In that scenario, sometimes there'll be multiple levels that are affected. So the injection itself, if one level gives relief compared to injecting a separate level, it helps confirm where the issue is, if it's one spot versus another or both. In terms of other structures, we talked about the diagnostic yield of injections for the facet joints and SI joints. So if people get relief with injection, we know that's the problem. We can target it appropriately. So the diagnostic yield still is high for us clinically.
Awesome. Thank you, Kinjal. And again, we'll have more questions at the end here for those who don't want to stick around for the questions. All right. So Matt Chapman is our native son of Charlotte. Is going to talk to us about advances in complex spine. And I've given Matt some of the questions that have already come up so that he can start speaking to those. Thank you.
Thank you all so much for coming out tonight. It's great to see such a big crowd. Unfortunately, you're here because you have some of these problems. Hopefully we can help you with them. So complex spine is a little bit of a black box. It's a whole bunch of different things. It can be scoliosis, it can be kyphosis, patients who've had prior spine surgeries, whether they be fusions or non-fusions. And it can be patients with medical complexities, be it osteoporosis, be it nutritional deficiencies, bleeding disorders, heart, stroke, lung problems. All of those things can take what's otherwise regular, pretty run-of-the-mill spine problem and truly make the management of it complex. Specifically today, we're going to talk a little bit more about kyphosis and scoliosis. And these are abnormal curvatures of the spine. They can happen either when you're born, you can be born with them. They can happen through degenerative changes. You can have prior fusions that can cause them. Typically, they happen more in the thoracic or the lumbar spine. Those are subject to more stress. They can be subject to more degenerative disc disease, wear and tear, and things like that. We're going to look a little bit more at some of the strategies to halt or delay the progression as we go through. So these conditions can impact up to 32% of the population. But interestingly, about 68% of the population has these conditions but is asymptomatic or doesn't appreciate that they have these conditions. But when patients are impacted, they can have a significant impact on your quality of life, your ability to get up, walk around, do the things that you enjoy doing, do the things that you need to do to live a normal, healthy life. I think when you talk about treatment strategies for these more complex problems, as we'll see later, the fixes can be bigger, more invasive. We're certainly trying to use some of the minimally invasive techniques. But it's important to align your goals. And you as the patient have goals, your family has goals, the people that take care of you, and your provider will have goals. And I think it's really important to kind of line all three of those up and make sure everybody's on the same page, because it really takes a team approach to manage these problems, to do it well, and to do it efficiently. it's important to target the time. I mean, you could spend your whole life, or you could spend days dedicated to these problems. It's important to get the biggest bang out of your buck, too. And once you start a regimen, I think committing to it and giving it a good, honest try is worth it. There's a lot of factors that can affect the treatment before we even get into what those things are. Your age, your functional level today can affect what we can get you back to going forward. Your bone quality and your nutritional status, as well as a bunch of other different things that we've already mentioned and will continue to mention, can affect that. I think one of the most important treatment strategies for this, for preventing the progression, for managing the pain, for keeping it from getting worse, if you need surgery, starting with physical therapy. And one of my favorite kinds of therapy is aquatic therapy. It unweights your spine. It gets you usually into a warm pool. You can increase your heart rate. You can increase the resistance that your arms and your legs have moving it. That'll make you stronger. It'll help your core get stronger. And it can really kind of propel you to the next level in terms of your functional ability. Certainly assistive devices. Nobody wants to be on a cane using a walker, wearing a brace. But those things really can help you. They can temporarily help you. They can get you through a tough time. They can get you getting into that therapy and improving things. And activity modification kind of goes along with that. You might need to take a little bit decrease in your activity in order to have a long-term improvement in your overall function and outcome. There's a lot of medications that we can give you. We'll talk about some of them. And then, frankly, I think things like what Dr. Parikh talked about, injections to identify your problem so that you can target the solution in order to give you the best outcome, are really important. So when we talk about medications, anti-inflammatories, a lot of these degenerative changes are inflammatory. They cause inflammation of the muscles, the nerves, the discs. Anti-inflammatories are really a mainstay of the treatment. Tylenol, muscle relaxants are also very helpful for pain control and getting you able to engage in those therapies. We try to avoid narcotics. Certainly they can be indicated for chronic pain. I think it's important, if you are on narcotics and you're going to be on them for a long time, to be managed by people who are good at doing that. We as spine surgeons are not very good at that. I mean, frankly, that's the reason there's a pain management specialty. At the Spine Center, we certainly provide temporary and some kind of slowly extended pain management, but really it's important as part of your treatment care to have somebody, if you're going to need narcotic medications, to have them for a long, sustainable time. Bone density management and nutritional supplementation are also really important points. Speaking specifically to bone density, there's a new medication called Forteo, which is a synthetically made hormone. It's injected daily. And this really was originally designed for osteoporosis management, but it's kind of revolutionized complex spine care. It's been shown that if you initiate it before surgery, it can increase your fusion rate. It can increase the rate of a successful surgery by getting that fusion. It can decrease instrumentation failure, because we put in screws and rods, but those are just like paper clips. You can bend them and break them over time. So getting that solid fusion can help prevent that. And you can also decrease the rates of fracture around your instrumentation by having stronger bones going into surgery. When it comes to surgical treatment, I try and find analogies of ways to make it more relatable, because a lot of these things, I mean, you've heard about lateral inner bodies, you've heard about robotic screws. Sometimes you're just trying to plant a seedling. Sometimes you're trying to plant a big tree. A hand trowel, a shovel, those things aren't going to be very good if you're planting a tree. You need the backhoe. If you use a backhoe to go out and plant your home garden, it's not going to work. In spine surgery, it seems complicated and it seems sophisticated, but really, these are some of the underlying principles. If we decompress nerves, stabilize your spine, correct your alignment, and obtain a fusion, usually we can go on and get you a successful outcome. You've heard some about minimally invasive options, the lateral inner bodies, robotic instrumentation, and muscle-sparing options. I'm not going to go through the advantages that they've already covered. Those are definitely things that we are trying to bring more into complicated, longer, bigger surgeries because of all the advantages that you've heard about before. But as Dr. Laxer mentioned and referenced, a lot of the bigger, complex spine requires a bigger, longer incision. That certainly carries with it higher blood loss rates. There's medications and advances that we've been able to make with respect to that. So this medicine called TXA, tranexamic acid, is something you get during surgery for patients who are, have a propensity to bleed or are going to have a bigger surgery with a predictably higher blood loss. This medication has been shown to decrease your blood loss intraoperatively. It's been shown to decrease the transfusion rate of blood after surgery, which is important because we know that that can prolong your hospital stay and predispose you to infections. We also are now using more intraoperative neuromonitoring, which is where once you're asleep, if you're going to have one of these large operations, we put little needles and electrodes in everywhere from your scalp down through your arms and your feet. We're really able in real time to monitor your spinal cord and your nerves, and that gives some protection because we can anticipate neurologic changes and we can correct them. The worst thing we want to do is we want to do a big operation, accomplish all of our goals on an x-ray, and then have you wake up and have a paralysis or not be able to use one of your arms or legs. That's not a win. And so we can use this in order to better kind of target and guide our care on the fly in the operating room. And as I mentioned, some of the times if there's bigger deformities, there's bigger fixes. You can see going from kind of 1 to 6. In the top one on the left, number 1, we're just doing a little bit of bone resection in order to correct a curve or a kyphosis, the bending forward. Whereas at the bottom right, number 6, we're going in and we're actually taking out 2 whole vertebral bodies, and that really cuts your spine in half and lets us realign it however or wherever it needs to be in order to obtain the realignment. That's a very rare thing. That's something that we try and avoid at all costs, but sometimes it is indicated. There are tools, though, that can help us with that. There's a program called SurgeonMap, which is something that we use. This is a patient that actually Dr. Darden and I operated on together. He had a prior surgery. You can see way down low in his spine, he had the screws and the rods, and above it, he was bending forward. So we were able to take his x-rays, import them into this system, and then we can put the anatomic landmarks in there. Because we know that when we look at these x-rays, there are some things that we can measure that correlate with patients' pain and their disability. So we're able to see, you can see down here, these things labeled wedges and cages, and those are kind of fancy terms for the bony work to correct that. You can see how we can pre-plan how we're going to fix, where we're going to fix, and the strategies that we're going to employ. And then we're able to go and execute these operations where we can really stand patients back up. We can make their x-rays look as we anticipated that they would. And you can see that by doing a surgery in the lumbar spine, the low part of the spine, the rest of this patient's spine is much straighter and looks much more like it's anatomic the way it's supposed to. So these are just his x-rays, and those are good. Those feel good for us to look at. But it's really more important because patients who stand originally like this are now able to stand up and walk around through the world the way that we all want to. Sometimes when there's prior fusions that are bigger and these malalignments or these flat backs, we need to use this software in order to really perform bigger operations. We're also able to pre-plan these so that we can obtain better corrections and have patients stand with their heads above their hips, which is how, once we get up and we start walking when we're 2 years old, that's how we want to walk for the rest of our life. So using these strategies, we can hopefully gain kind of better success doing that. And I think that complex spine and these big deformity surgeries, there's definitely still room to grow. I mean, you've seen robotics. We're trying to incorporate that into the complex spine practice, lateral interbody fusions, tissue sparing, soft tissue sparing. But looking at modifiable patient-specific implants, further minimizing the soft tissue disruption, and then continuing to get a better understanding of how spinal alignment really affects patients' quality of life are all kind of areas that I think at the Spine Center we're committed in continuing to study.
So Dr. Chapman, often patients who have scoliosis, like you've shown, often have many medical problems, such as osteoporosis and other issues. How do you go about working up those patients to make sure that they are able to go through surgery as safely as possible?
So all of these operations are big, they're risky. There's certainly medical comorbidities that increase the risks. And a lot like whether it's with operating with one of my partners, it takes a team approach. It takes a team approach to your overall medical care. So patients who are going to undergo these big surgeries usually end up seeing a hospitalist at least, typically a cardiologist, nutritionalist in order to better their preoperative nutrition to help them heal on the back end. If there's osteoporosis, rheumatologists are the folks that specialize in that. They're the folks that are best able to treat osteoporosis with Forteo and decide what is the correct medication, when, and how. And so really, Dr. Milam, it takes a whole team. It takes a team approach from the day we meet through the end of your care, be it employing other members of the medical community or other folks at the Spine Center.
Awesome. Thank you. So the one thing I'd like to say, so as you guys have been passing up cards, I've been kind of putting them in piles to hand to each of the guys, and they'll come up later on and talk. But one of the other things that's helpful with the cards is it kind of gives us a sense for some of the topics of the things that we do that we will be talking about at the future seminars. And some of those may be SI joint fusions and treatment of SI joint pain, cervical disc replacements, laminoplasty, which is an alternative to cervical fusion, Coflex device, which is another device that helps in lumbar spine surgery and avoid a fusion, kyphoplasty, which is a cement procedure to treat fractures. We use a technique for monitoring the pedicle while we're putting in pedicle screws, so it's another called Pedigard, which is a technique that is similar to the robot, yet different. And questions about physical therapy, spine physical therapy. And we actually have several excellent physical therapists who I know would love to come and talk. So I think we'll bring them in for the next time around as well. With that in mind, Alicia is also one of our physiatrists, and she's going to talk about electrodiagnosis, when and why.
Thank you. Well, welcome everyone. Thank you for coming out tonight. Electrodiagnosis is something near and dear to my heart. Not a lot of physicians perform electrodiagnosis, so chances are pretty high if one of your surgeons at OrthoCarolina orders this type of testing for you, you are going to see me, which may be good, may be bad, depending how you feel about electrical shocks and needles, but I promise it's not as bad as it sounds. So by a show of hands, who here has had an EMG? Okay, a couple of you. That's unusual. Most people have no idea what it is, and so that's why I thought this was a particularly important topic for y'all to listen to, because who knows, this may be in your future. So the first question is, what am I talking about? Electrodiagnosis is a tool that we use to investigate the peripheral nervous system. And so that means everything outside the spinal cord. All the nerves that are large enough that we decided to either number or name, this test can look at. And that's not nearly all the nerves you have in your body. That's just a select few. But fortunately, most nerve issues come down to these larger nerves, and we're able to investigate them. So this test is known by many different names. Sometimes your physician will call it a nerve study. Some will call it an EMG. Some will say electrodiagnosis. Some people will say, just go get this test done, and they don't tell you what it is at all. It's generally a two-part test. The first part we refer to as a nerve conduction study, and that is meant to test the nerve's ability to transmit an electrical signal from point A to point B. How fast can that nerve do it? Is there a stop in the middle? And that's what that's looking for. The electromyography is known as the needle examination. It is a very small needle with a microphone on the tip of it, and it collects electrical data from the nerve that transmits to the muscle fiber. So you can actually hear it. And if you have this test done, you'll listen. It sounds like static. And normal communication sounds one way. Abnormal communication sounds very different. When do you need an EMG? Fortunately, most of you will never need an EMG. It's a very specialized test. We only order it for certain things. Your physician needs to have a pretty good suspicion that you have a nerve injury in order to end up having this test ordered. Symptoms of nerve injury are pretty broad. It can be pain, weakness, numbness, tingling, not having the stamina in a certain muscle. The muscle atrophy, which is wasting of that muscle. You can see there's a difference in size if you're looking at one side versus the other. Those are the typical reasons you may get involved with this test. The timing of the test is very important as well. When a nerve is injured, this test cannot pick up that injury immediately. The nerve takes about 10 to 14 days to degenerate enough that the needle will actually pick up the electrical signal change. And so it's very important to wait out that 2 weeks before this test is ordered. Otherwise, you'll have a normal test and it doesn't mean anything. So recently I had a snowboarder who had an injury, couldn't lift his wrist. He was ordered to have this test done 5 days after the injury, and unfortunately we had to ask that he come back at a later date because that test would not have been, helpful in that situation. So on the day of your appointment, what is it going to be like? First thing, you're meted by my staff. They typically will take you to a room, make sure they have the correct patient, make sure that we are doing the correct limb, and that you know exactly what you're going under. I have all of my patients warm their limbs prior. The reason being, nerves function slower when they're cold, especially in the winter months. A lot of people come in, their fingertips are cold. That will give you a positive test that isn't necessarily clinically useful. So you will warm for at least 5 minutes, whether it's your hands or your feet, prior to having the test. When I bring you into the testing room, I always talked with my patients first. What symptoms are you having? How long have they been going on? What started the symptoms? Gives me a better idea of what to look for on this test, because this test is not the same protocol for every patient. Different nerves are studied depending what you're telling me. I also do a quick physical exam, test your strength, test your reflexes, your sensation. Most of the time I'm watching you walk. I have you walk in front of me as you enter the room so I can see what that looks like. And again, that helps me determine which nerves need to be tested. The first part of the test is always the nerve conduction study. Most of my patients are laying flat on their back, and that is for the arms and the legs. I attach electrodes to the limb that I'm studying, and those electrodes are little stickers that I then attach to the machine. I have a probe that gives a little bit of electrical stimulation. It feels like hitting your funny bone over and over again. And every time I stimulate the nerve, a waveform comes up on the computer, and that waveform should take a certain shape, it should be a certain height, it should pop up on the computer in a certain amount of time. If any of those things are off, that is an abnormal finding, and that gets jotted down in the report. Once that is done, we move on to the needle portion of the examination. For your arms, you're typically on your back, and same for your legs. Sometimes I have you turn side to side if I need to get to a particular muscle. But most people are laying down comfortably. And this is really for my patients who are a little wary of needles. I've had patients get a little lightheaded at times, and so that just is safer for you, safer for me, so we don't have any issues. The needle examination, although it sounds uncomfortable, it's really not too bad. It's about the size of an acupuncture needle if you've ever had acupuncture. It feels like a little bee sting going in. Most of the time you are relaxing and I'm listening to the machine. There are some movements you have to do so that I can see that the muscle fibers are able to respond when I want them to, and then we move on to another muscle. Why would anybody order this test? It doesn't sound fun. Some people don't think it's fun, although I would argue that. This test, really, its purpose is to help physicians figure out, is a nerve injured? Where is it injured? MRIs are great. They can show us the structure of a nerve, but they can't tell us where the nerve stops functioning properly. Ultrasounds are great. Again, ultrasounds look at structure, they don't look at the function. And so that's where this test really picks up. It's helpful in surgical planning. So my mother-in-law broke her wrist about 2 years ago, and she needed surgery. While we were getting her prepped for surgery, the surgeon wanted to know, hey, does she also have carpal tunnel? Because if I'm already in there, I might as well do that at the same time. So that changed his planning. I've had patients sent to me by our spine surgeons. Dr. Laxer is probably the most recent one that I can remember. where his question was, okay, this MRI shows a spine that has a lot of levels of degeneration. Do I need to operate on all those levels? Or maybe it's just one nerve. And so I'll look at the different nerves coming out of the spine to see if the operation really does need to be the entire part of the spine that's degenerated, or can we limit it to one or two levels? The other nice thing about this test is it follows the evolution of a nerve injury. So this test can give you a rough timeline. Nerve injury in the first 3 months looks a very specific way on the needle exam. When the nerve starts to heal itself, it looks a separate way. And when the nerve unfortunately has tried to heal, it just won't, and we term that a chronic injury, it will look again a different way. So we can follow that nerve through its healing process to see if we're on the right track, or maybe we missed the boat and now you're dealing with more long-term issues. So this sounds fun, right? Everybody wants an EMG now. And hey, if you all want to come in, I do arms, legs, and you know, I would be there all day. I've got residents that I need to train, so come on by. But fortunately, not everybody needs to come see me. Really, it goes back to if we can't determine where your symptoms are coming from, we may look at the nerves. If we know where your symptoms are coming from, but we don't know how extensive this injury is, you may get an EMG. Surgical planning, let's say you had surgery and you're still having some problems. We can look to see if there's another nerve involved, if that nerve still is in the healing process, and try to troubleshoot that way. Most people can have an EMG. There are some medical problems that we have to be careful about. If you have an LVAD, which is a machine to help heart patients who are on the heart transplant list, you cannot have this study. Quite honestly, your nerve problems are probably the least of your worries at that point anyway. But we would have to wait until that machine was no longer in place. Lymphedema, that swelling of the limbs, it can happen for a lot of different reasons. We don't like to puncture the skin with needles in someone with lymphedema. They are at higher risk of infection, so I avoid that. It also makes the test a lot more difficult. With that amount of swelling, I need to increase the electrical stim. It's very uncomfortable, and so that's not a great situation. Open wounds or infections where I have to do the exam, I have to avoid those areas, so you may not get a complete exam. We usually ask your physician to wait until after that has cleared. And then caution in patients with pacemakers and defibrillators. Most physicians at OrthoCarolina are not ordering studies that require me to study the nerves near those areas. So I really haven't run into that problem. So I think electrodiagnosis is helpful. I'm fortunate my partners refer patients to me a lot. We work very well together trying to figure out which nerves are injured, how to repair the injury, and then kind of follow the healing. Not everybody needs this test. It really is a combination of what are your symptoms, how long have you had them, what sort of treatments have you had, are there other explanations for your pain? Because not all pain is nerve pain. And so I always caution my patients, if this test comes back normal, that's a good thing because you don't have nerve damage. Now we got to find what is causing the issue. And then although this test is mildly uncomfortable, most people get through it just fine. I encourage you to not Google this test. There are some videos out there that are quite scary, and a lot of patients have told me about them. So if you are interested in what it looks like, we do have a video on the OrthoCarolina website. You'll get to see my face again, unfortunately, and it goes through a little bit of the test just so you know what the equipment looks like. But hopefully this has been helpful. If I see you, I'll guarantee you have a smiling face doing your test, and we'll get through it together, okay? Thanks for coming out.
All right, Alicia. So one of the questions for the audience is if you have a peripheral neuropathy diagnosis, I guess first and foremost, how would you go about diagnosing peripheral neuropathy with an EMG? And then the subsequent question would be, is there an exercises that can be done that might be able to help with peripheral neuropathy or other treatment for that?
So that is a good question. There are a lot of different types of peripheral neuropathies. Peripheral neuropathy that affects the large fiber nerves can be picked up on EMG. Peripheral neuropathies that affect small fiber nerves, like those found in my diabetics, those typically don't come up on EMG. What you're going to see on electrodiagnosis is the nerves will transmit information slower. And so we look at something called conduction velocity, we look at onset latencies, all those things will be prolonged in someone with neuropathy. There's no good exercises to prevent neuropathy, to make the symptoms go away. Really, prevention is key. If you have diabetes, keeping your blood sugars in check is the #1 most important thing you can do to prevent peripheral neuropathy. I see peripheral neuropathy a lot in patients who've undergone chemotherapy. There's not a lot we can do to prevent that. There are some medicines that can help, and I encourage you to reach out to your physicians to talk about those.
Awesome. Thank you. So Dr. Al Ryan is going to be talking to us about an FDA trial on ablation of the basovertebral nerve. And I know you're asking, what is the basovertebral nerve? And the good doctor shall tell us. Thank you.
Good. Thank you, Alden. Well, thank you, everybody, for coming out. I'm the caboose, and hopefully make this thing quick and move along. So the Spine Center was started 26 years ago, and part of the mission of the Spine Center when we first started, and we were challenged by the department chairman at Duke to make it something more than just take care of patients. Obviously, that's our highest priority, but we asked Leonard Goldner, the department chairman at Duke, what do you mean by that? And he said, give back to the community, research, teach. And so this is where part of this has led to, what I'd like to do is just talk about our participation in an FDA trial. And in this particular trial, I'll get into the details about it, is that we've been integrally involved from literally day one, before the product was developed, as it was being implemented, multiple trips to Washington, D.C., talking to the FDA, setting up the trial design, proctoring the trial in Germany and the United States, and then finally analyzing the data. And so I was going to show you what it takes to get a product through the United States FDA. So for medical devices have a lot of different subcategories to be dealt with, but the very first one is that you have to have an original idea, and you have to protect that idea with patents. The second is that somebody has to have some very deep pockets to make it happen. And you can either start your own company and try to get funding, or you can go about it if you're a public company and try to invest. But at a minimum, $30 million is what it takes, and a lot of them can take a heck of a lot more than that. The third part, which is where we come in, is you need research centers. And over time, OrthoCarolina has developed into one of the bigger research centers in the United States in orthopedics. Bruce Darden, who just left for a second, is one of the chairs of our Orthopedic Research Institute. And currently we have 250 research projects going on within the field of orthopedics. And then the last thing, when you meet with the FDA, the first thing they want to know when you design a trial is your product safe? Are you going to hurt the citizens of the United States? And if you're not safe, it's not going to be delivered to the United States citizens. And then the second product is that you have to prove, does it work and is it effective? And that's where the tricky part gets in an FDA trial. So 25 years ago, believe it or not, a nerve was discovered that goes into the vertebral body, and it's called the basovertebral nerve. And the basovertebral nerve creates pain in some patients. It's a mediator of pain. And so the idea or the concept was, could you do something to that nerve to take away the pain in the back? And so I'm going to show a video of what the company did. And hopefully it works. So the company's name is Relief that has funded this study, and this is what we've been involved with from the very beginning.
Anatomic studies performed over the past 20 years have confirmed the basovertebral nerve's role as a source of chronic low back pain. The basovertebral nerve is an interosseous nerve that enters the vertebral body through the basovertebral foramen. It arborizes near the center of the vertebral body, sending branches to innervate the superior and inferior end plates. Histological studies have concluded the basivertebral nerve has the ability to transmit pain signals. The density of the basivertebral nerve fibers at the end plates increases in damaged and degenerated end plates, linking the basivertebral nerve to chronic low back pain. The Intercept procedure was developed to target the basivertebral nerve for the relief of chronic low back pain. Using a transpedicular approach, the introducer is advanced under fluoroscopic guidance towards the target. The curved cannula is utilized to create a channel to the trunk of the basivertebral nerve. The RF probe is inserted into the curved path and placed at the target. Bipolar radiofrequency energy ablates the basivertebral nerve to stop it from transmitting pain signals. The Relievant Smart trial.
So I'm going to stop it there and show you what, on an MRI scan, what we were trying to accomplish. Before, this is the tip of the basivertebral nerve, and it's 6 weeks after, when you looked at the MRI scan, you can see how the tip of the nerve had been ablated. So when we went to the FDA, we designed the trial, and the very top heading is what the FDA requires for a medical device to get approved in the United States. Number one, it needs to be a level 1, which meets the highest level of studies that can be conducted. The second is its perspective, meaning from this point going forward, you're going to collect data. The third is that it's randomized, that if you are the patient that enrolls in it, you don't know if you're going to get the treatment or the control arm. And then it's double-blinded. The patient doesn't know, and then the person following after doesn't know. And then the last part, which is what the FDA asked in this particular study, was that the control had to be a sham. The patient was put to sleep and subsequently was in the operating room for 30 minutes or so and was not informed whether they had the actual treatment or whether it was a sham procedure. So to get that approved at the hospital systems, it has to go through what's called an internal, an IRB, investigational review board, and they have to give you the thumbs up or not, because obviously there's some ethical situations about putting someone to sleep without and them ultimately not having any treatment performed. So when it was all said and done, there were 225 patients that went through this particular procedure. There were 15 sites in the United States. OrthoCarolina was one, 3 in Germany. And then they followed up at 2 weeks, 6 weeks, 3 months, and 12 months. And so when it was all said and done, the results were that 75% of the patients that had the procedure, that had the nerve burned, saw a dramatic reduction in their pain. 75% of them had a dramatic reduction. And we agreed with the FDA that you had to have a 10-point reduction in pain on the pain scale for that to be considered a valid response. And that the results were sustained at 12 months and 24 months. And then it was concluded to be safe. And here's the part that everybody has had a hard time trying to interpret at first. 50% of the people that were taken to the operating room that did not have the device inserted and then it turned on, 50% of them, 50% said that their pain was dramatically better. This is people that had had back pain for, on average, 3 or 4 years, that say on a visual analog scale was 50 on a 100-point scale or greater, 50%. But fortunately, when you got down to this statistical analysis, they take the difference between the 75 and the 50 and they look at the total number of patients involved, and it typically takes statisticians to create a value and tell you whether you got the thumbs up or thumbs down. So as a result, the conclusion is that this ablation of the nerve is successful in alleviating chronic low back pain in the right patient. It is statistically significant to a sham. It is safe. It receives FDA approval, and starting in April, it will have limited introduction in the United States. And I think we're going to be one of the sites that will have this particular procedure available. And so, oh, where's the thing? They took away my cheers slide. Okay, that's it.
All right. So Al, tell us a little bit about what the placebo effect is.
So placebo, in this particular case, was a sham. A placebo is a tablet or a pill, or in this particular case, it's an actual surgical procedure. And it's used as a part of a control. And the FDA realizes it, and we all know that, that there is going to be somewhat of a positive effect from the placebo effect. And the reason behind that is that when you enroll in one of these trials, is that even you hope that you're going to get better, and the fact that you hope can translate into significant reduction in pain. And I'll tell you an interesting story about the very first person one of the first people enrolled in the study. They filled out a form at 3 months and 6 months and 12 months, and they specifically asked the patient, do you think you had the treatment, or do you think you had the placebo effect? And one of the first persons said his pain, he'd had back pain for 3 or 4 years and tried physical therapy and everything else you could try. And he specifically said, oh, his pain was gone. And he goes, I hope that I had the treatment option, and I'm going to be very ashamed of myself if I had the sham operation.
And so in the FDA trial for the basic vertebral nerve ablation, what were the age range for the FDA trial?
Right. So the specific criteria for this was you had to have on your MRI what are called modic changes, MODIC, and that typically is in the range of 40 to 55-year-olds. That's the most common age for modic changes. And like any product that's out there, the FDA will initially create really tight windows for clinical indications, and then once it's found to be safe, it will start to branch out and find other uses as well.
All right, awesome. So what I've done, like I said, is I've given out the cards to each of the panelists, and we'll have them come up and kind of go through them. We bluntly, given the time, we're probably not going to get through all of them. So one of the questions that arose was, what are we going to do with all the questions we don't answer? And so the short answer is, this is, as you can see, is videotaped. So it's going to be on the OrthoCarolina website. And with that, we're actually going to type up the questions and answers and put them on the website as well. So they'll be available down the road. In posterity for your friends who weren't able to come, and family members, and more importantly for yourself, when you've forgotten what we said, you'll be able to go back and look at it. So one of the questions, I'll kind of start off with a couple of high points, and then we'll go to Dr. Segabarth. So physiatry, we talked about that, but basically those are rehabilitation physicians, non-operative spine providers. They obviously in the spine center do our diagnostics of EMGs and as well as injections. Morbidity is a word that I think we used early on, and what that means is making you sick. So when we do surgery, we cause harm. I mean, we're making an incision on your body, and when you do that, things can happen to you that can be harmful to you, such as infections or and again, putting screws in the wrong spot. So if those things happen that aren't necessarily unintended, well, they're unintended, but they can still happen even with the best of intentions, that is morbidity. So basically, when something happens to you, that is a sickness from the procedure. Foraminal is the word for the little hole where the little nerves come out of the spine and go down into the arms and legs. Who makes decisions about surgery? Does the insurance company tell us what to do? And the short answer is the insurance companies don't tell us what to do. They tell us when we can do it. So if you have a surgical problem and you haven't gone through all the quote-unquote check boxes that the insurance company feels is necessary, such as physical therapy or injections or studies, they do dictate or encourage us to go through those check boxes. But ultimately, the decision of whether we use a robot or whether we come in through the side or the back is left up to the discretion of the surgeon. We at OrthoCarolina, so what network are we in? We are independent orthopedic practice, so we are in neither the Novant or now the Atrium network. We work in both health systems. Let's see. Here's a good one, sorry. So if a patient sees one of the physicians at OrthoCarolina and has a condition, do we cross-refer within the group? So in other words, do each of us have subspecialties within spine? The answer is yes. And if you're seeing member of the spine center and they do not feel like they can take care of your problem as well as someone else in the spine center, then you'll often be sent to someone else in our group. Let's see. So if a patient has damage to some kind, if the patient has damage in all three of the areas of the spine, the neck, the mid-back, and the low back, where do you typically start? And the answer for that is basically, number one, usually what hurts the most. Number two, if you have spinal cord compression, so if your neck or mid-back, if the spinal cord is being compressed, there's a risk of you potentially losing more neurological function or being paralyzed. We use the term paralyzed a little bit loosely there, but basically becoming weaker. And so that area of the spine would typically be chosen as the first place to start with your surgery. Even though you may be having more back pain, we'd be more worried about your neck or your mid-back causing permanent damage. Where in Charlotte does aquatic physical therapy happen? I don't know all of the places, but I know we have aquatic therapy at OrthoCarolina. On Randolph Road, it's our spine physical therapy. And Marion Deal, yes, thank you. Can you speak about the Coflex device? Yes, at our next seminar. Too much time for that one. And Dr. Segabarth, you were up.
All right, thanks. I think I've collected most that are relevant to my topic. I'll try to get through them. May have some generic short answers, but if I don't, we'll be like my clinic and I'll be an hour behind. So I'll try to not talk so much. The first question is lateral access the same as X-lift surgery? And so yes, it's comparable to soda. There is Coke, there's Pepsi. With lateral access surgery, there's X-lift, there's D-lift. There's a lot of different names for it. So it's a brand of a particular vendor that makes the implant. So, but it is lateral access surgery. So I was just using a more general term. Why would you look only at pain relief in supine and dynamic postures with minimally invasive surgery? Would you not look at how a person positions and postures during functional movement? So the answer to that is yes, we do that as well. That's a good question. And, I think this comes from a mechanic or an engineer, maybe, huh? No? But good thought. So that's even part of our exam. Even watching the patient walk in the room often tells us, oh, this guy's got a disc herniation, or oh, I bet she has stenosis. And so we look at that to help us figure out what the diagnosis is. But then if we're going to do a structural surgery where we're going to do a fusion, we're going to change the structure, we also use, X-ray where you're standing up versus an MRI where you're laying down and see. We measure out angles like Dr. Chapman had shown you, and we try to see what moves and what opens up, and it gives us an idea of kind of how to approach that. So we look at it mechanically and functionally just to really get the diagnosis and determine what the options would be. Is MIS an option for a grade 3 spondy? So grade 3 means a slip where the bone is shifted forward quite a bit. And this is someone that declares they're a little overweight, maybe. It depends. It can be. A high-grade slip, often you can't approach from the lateral because you got to get the bones to line up to be able to put something inside them. But a dynamic slip, meaning if this reduces or shifts back, then oftentimes we can do that. And actually, lateral access surgery performs pretty favorably with obese patients because you're avoiding most of that. So can MIS be done from the front instead of only through the back? And the answer there is yes. Also, we can go the front, back, side. I actually don't think of the skin incision as the minimally invasive part. I think more of muscle sparing and using different planes so that there's faster recovery. And sometimes you end up with a larger incision if you go through the front because that's the safest way to do it. But you can avoid all the muscles of the back, and so sometimes that's the best option for a quicker recovery. How long are you under anesthesia for MIS? I'd say the whole time. So I mean, it's a good question because is it saving anesthesia time? Well, there's a learning curve to MIS, and sometimes the surgery that you could do open takes twice as long to do MIS. Well, then you're not there yet, and until you get there, you have to get through that learning curve to be able to offer the patient the best option. And until I feel like I can do something MIS better or more effective or efficiently, then I would probably do it open. And so it just depends on what the goals of the surgery are. What levels of surgery are most effective with MIS? And another stupid answer, I'd say the level of the pathology. Wherever the problem is, that's probably going to be the most effective level. So in the lumbar spine, maybe to your point, there are some levels we can't access through the side. So if you get down to the bottom disc level, you can't get there. The pelvis is in the way. So it would be L4-5 and above up to when you get to kind of the diaphragm. But that's where most of the pathology or problems are. But we can't really get to the bottom disc through this approach. Does minimally invasive surgery versus open surgery have more scar tissue? And in terms of the canal, getting in where the nerves are, if you don't enter the canal, there's going to be less scar surgery there. Less scar from the surgery, rather. So, yeah, I would say that's a good advantage of the MIS from the side. Am I a candidate for MIS with severe scoliosis? And I would say yes and no. It depends. We'd have to look at x-rays. We'd have to talk to see what the problem is and figure it out. But oftentimes, we use hybrid techniques. If we're doing a deformity or a complex case, it might be we're going to approach this level that has collapse from the side, and then we're going to do the open part from the back because we can't achieve it with MIS. And so oftentimes, it's a combination of procedures. So I've been told I need 4 rods and screws. Am I a candidate? Could lateral access help me? Yes, possibly. I mean, that might be an option, although not everybody is a candidate for that. A lot of it depends on the anatomy, the problem, how dynamic it is, whether, and because with this approach, it's not that there aren't problems. You run into other problems. You got bowels, you got vessels, you got other things. The anatomy has to match up for you to be the right candidate. Another patient that's had multiple diagnoses and procedures, had some recommendations. Should they get a second opinion? And I would say yes, always, and I tell my patients the same thing. You need to really be on board with your surgeon or your provider, and they might be telling you, exactly the right thing, the best thing for you, but you need to know that, and if you're not comfortable with that, you need to talk to somebody else and see what the options are. The challenge becomes when you get 3 different answers. And so to the point earlier, do we pass things around ourselves? Yeah, and actually we meet every week and we talk about cases as a group, and not just the surgeons, but also the physiatrists, and so we get input from each other, and I think that's helpful, and one thing we do that's unique to our group. It says recovery time. What's the recovery time for a lateral? And that depends. It's kind of like, well, if you drank 8 beers tonight, some people would recover in 4 hours and some people 4 days. So it depends. I mean, surgery is an insult, but a lot of it depends on the medical conditions and the surgery itself and what you're trying to accomplish. But the patient I showed you that's 2 weeks and come back and walking with, without pain, there are some folks that going through this side have some weakness of the hip flexor, and that goes away 90% of the time by about 2 weeks. But you have trade-offs there. So, kind of the same question. Is fusion effective for someone who's still working active construction labor? And I would say if you need a fusion, not everybody needs a fusion, but if you need a fusion, yes, it's a pretty hardy procedure. So implants in the front and back, and it used to be we would not have rods and screws. We'd put everybody in a brace, and we hold them there for a while and tell them don't bend. Well, now we have these devices that can hold things together. We don't use braces typically for those scenarios, and we get you back to function as soon as possible. So the goal of surgery would be to be able to get you back to work. When will the medical or insurance industry cover laser spine surgery? They have good track record and all. And I don't know that I can speak to that, but I will say that the one concern about laser spine surgery is everybody's a candidate no matter what the pathology, and so it's kind of like if all you've got's a hammer, everything's a nail. It works for some things, and so if you have that one little thing that you can access and accomplish with a small, just like MIS, with a small targeted procedure, it might work. But if you try to apply that to 10 different other problems, then it might not work. So until that's proven that it's distributed appropriately, it's probably not going to gain a lot of traction. So I think that's it for my section.
So just in the interest of time, I've picked a couple of questions just to go through things that were not already discussed. How does robotics interact with MIS? Basically, it's a tool. MIS could be performed without robotics with different techniques that are available. How effective are robotics at lowering the cost of surgery? It actually increases the initial cost of surgery, but like many things, we hope that if you do it better the first time, then you don't have to go back and do something else. Also, if the hospital stay is shorter, if recovery is faster, then it's less expensive on the front end. People can potentially get back to work earlier as well. How much training do physicians receive on the Mazor X? It usually starts with a day, but I can tell you that the training continues for as long as you decide to continue this technique. And when you start doing this, you develop a very close relationship with members of the company who are incredibly helpful at doing anything that they need to improve the process. With spinal stenosis, spondylolisthesis, and scoliosis, is spinal fusion the only option? I would say no. You heard a lot today about fusion techniques. I would tell you that in my practice, as an example, most of the procedures I do for patients are not fusions. Most of them are small operations designed to get people back on their feet, back to work. Fusion is occasionally an option as the first choice in the cases I showed you, or if the initial surgery is not as successful as people hope it is. How much mobility is lost with a fusion? It's interesting because the majority of patients actually gain mobility after they have a fusion, and that's because they're in so much pain prior to the fusion that their pain goes away and their mobility improves. The main issue with the fusion is the impact it has on the other areas of your spine, because if you fuse an area of your spine, the other areas have to work harder to achieve the same level of function. And the analogy I give patients is if 5 people are carrying a sofa and one person drops out, the other 4 have to work harder, so they can't last as long. And it's the exact same thing that happens in your back. So that's the long-term issue with fusions. Thank you all again for coming. It's not over, but just thank you all for coming.
Thank you all for all these good questions. I always tell my patients there's no such thing as a bad question, so all questions are good questions. So the first question is, with exercises that relieve pain in the back and leg, what are the risks to doing more damage to the back and nerves in the spine? So typically when you're in a sitting forward position, so if you're sitting down or if you're sitting down and lifting something, you put 2.5 times more pressure on your discs compared to a standing position. Compared to a laying position, you're putting 25 times more pressure. So typically I tell my patients who are avid with exercising, avoid deadlifts, squatting, rows. Just heavy lower back exercises can put more pressure on the disc and cause more harm. Another thing I like to talk about is just yoga. A lot of doctors are emphasizing yoga as a good physical therapy type modality to help improve back pain. However, with patients with spinal stenosis, yoga typically is not the best thing because it does cause people to be in an extended position for long periods of time. There are protocols with physical therapy for, typically with stenosis, we want people doing more flexion-based exercises to open up the spinal canal. With lumbar disc herniations, we have something called the McKenzie protocol, where you have your back in more of a hyperextended position to help relieve pain symptoms. The next question is, if you've had a spinal injection lately which gave you no relief, will further injections be of any use or redundant? And that's a great question. I tell most of my patients that our goal is to minimize the amount of injections I do. So I tell a lot of my patients after the injection that I hope I never have to inject you again. Our goal is always to minimize what we do. Physicians can get overzealous with trying to treat pain aggressively, but if things aren't working quickly, we move on to other options. So our goal is not to continue to do injections. The next question is, I've been getting injections for 20 years. My endocrinologist has told me I should not get any more injections. What are my options? My pain doctor's telling me I can only do steroid injections for relief. Chronic use of steroid medication and overdoing it can cause suppression of the adrenal axis, which can cause systemic side effects. So for my patients, if you come to see me, I kind of become your gatekeeper of steroid medications. Because most people are getting injections from other people, from their primary care doctors. If you go in with wrist pain, they may give you a cortisone shot in your wrist. If you have shoulder pain, you may get a cortisone shot in your shoulder. But these things do accumulate with time. So my goal is just to kind of monitor what you're doing and make sure we're not overdoing the amount of medication on your body. Typically, from my standpoint, from a spine standpoint, 6 steroid injections of any type in the spine are the max that I like to do per year, and I have very few patients who get even up to 6 injections. So again, we minimize what we do. Next question is what steroid medication is used. We use a multitude of different steroids. Typically use thicker, cloudy steroids called Depomedrol and Celestone in the lower back from the L4 levels downwards. Above the L3 level, we use a clear steroid medication called dexamethasone. Last question is going to be, what causes the nerves to feel like they're on fire after an injection? Typically, it's the lidocaine and just the fact that we're putting something in the back. The whole idea is that we're irritating a nerve that's already irritated. So the body doesn't like it, but our goal is to go slowly. We use a very low volume of injection. Typically, injections are not terrible. I tell patients that your pain level can be reproduced to what you're already feeling. It can be amplified temporarily. On the rare occasion, you can have an increased level of pain, which only lasts for a few hours, but by far the injections and the pain that's caused by injections is very low. Thank you.
So Dr. Bruce Darden, who was not one of our panelists tonight, but will be at our next one, is going to talk about some of the questions you guys had. I thought were very appropriate for him. Specifically, he's our director at the OrthoCarolina Research Institute, one of the co-directors.
Thanks, Holden. So I get the questions nobody else wanted. So one question came up was, how do we fund our research? And I think the implication is, are we draining the government coffers to fund medical research? And the basic answer is no. The federal government funds some studies, but they're usually large non-clinical studies, not looking at a specific clinical problem. So our research funding comes from basically 3 sources. The first one is from industry. So if there's a new product or new type of study that industry wants to to test, they will come to us. They have to go through the FDA, as Dr. Ryan mentioned, before they can solicit groups or universities to test their products. But once they do, they come to us, and they usually will basically help us defray cost to help pay our staff to test these products. And you really depend on a good staff to get a good, honest research. So if we're not dotting all the I's and crossing the T's, then what comes out of there, may not be what we hope. So that's one way we fund our research. The other one is from nonprofit foundations. And one thing that we're testing, with all the information swirling around using opioids, are there better ways to get people pain relief without getting them hooked on opioids? And the Duke Foundation, the Duke Endowment, is funding a research study with us. Every subspecialty in OrthoCarolina is testing a specific surgery and doing that without giving people opioids. So we hope to be able to address that as we go forward. So that's the second way we fund. The third one is through donations through either individuals or our physicians. 90% of our physicians at OrthoCarolina contribute to our foundation and help fund research in that manner. The other question, I even hate to bring this up, but it always comes up, do we do laser spine surgery? There's a very vigorous publicly traded company that talks about laser spine surgery. And the basic answer is laser in spine surgery does not work. It doesn't do anything to the disc or to the bone or to bone spurs to try to remove them. Basically, you can't put a laser next to a nerve or the spinal cord because it would heat up too much and would injure them. So laser spine is basically trying to, in my opinion, to prey on the fears of people for traditional spine surgery. It sounds too good to be true, and it usually is. Nobody in this city, in this state, uses it, and I don't know anybody that I respect in the country who does. If anybody, any of the guys know it, please let me know. I've been involved in research for 30 years, and I've never seen a peer-reviewed study on laser that's been done. So if you don't believe me, with someone having an axe to grind, look at some of the position papers. If you really go and dig deep on the internet, look at what the American Academy of Orthopedic Surgeons or the American Academy of Neurosurgeons say about using laser before you commit to that. And I'm not trying to disparage anybody in particular, but I'd rather you go to one of my competitors here in town who'll do a good job than go somewhere where you have a procedure that's not paid for by insurance and not get the outcome that you want. And the last one was, right, so sure. If you Google laser spine in Bloomberg, you'll get several articles that will shed a lot of light on the subject. But I encourage you to look at independent position papers before you commit to doing that. The last question was somebody with a degenerative disc in their neck. Is there any way to revitalize those discs? And the short answer is no, there isn't. The longer answer is our discs all degenerate. That's part of aging, just like gray hair and wrinkles. But that doesn't necessarily mean that that's the source of pain. So I encourage you not to make that immediate assumption if your primary care doc says, well, you've got degenerative disc disease. Don't immediately assume that that's the source of your pain, because usually the problem is more complex and it's not always tied into the disc. So just keep that in mind. Hopefully with more research in the next 15 or 20 years, there'll be ways to revitalize disc, but right now there's not. Thank you.
So I'm going to just kind of address a couple of questions, hopefully kind of in a broad format. I got some questions about ankylosing spondylitis, which is a medical condition where your body kind of autoforms bone that travels from your sacrum and your pelvis up, kind of up your spinal column. It can make your spine really stiff and rigid. In terms of advancements for treatment in it, we've gotten a lot better at medical management of it. From a surgical perspective, there's not a lot that we can do to slow, to halt, or to change the progression of it. But there certainly are medications that rheumatologists can give you that can alter and change the course of it. Within ankylosing spondylitis, from a surgery perspective, if you fall and have a fracture because the spine gets stiff when the bones form, when the bones kind of start linking together, we certainly can stabilize it and do things like that. We can correct it if it gives you a malalignment where you lean forward or off to the side. But we don't traditionally treat ankylosing spondylitis surgically unless those things are present. And then I got a question about a patient with diabetes with factor V Leiden, which is a bleeding kind of disorder or a blood clotting disorder. Kind of goes along with questions about osteoporosis and things like that. And really, is that a contraindication to surgery? And really that kind of goes back to the whole team approach. I think if you have a small problem or if you're relatively healthy, you can get away with not having as big a team. But for complex things with medical comorbidities, we tend to employ a lot more people, a bigger team. There's a bigger net to catch the problems and hopefully prevent them in order to optimize you for surgery. We certainly can't prevent complications, but we can optimize you and reduce the risk of complications. So I'm going to, in the interest of time, kind of keep moving.
All right, so I just have a few questions that I'll try to answer. One question is referring to a lower leg surgery, an Achilles reattachment that someone had, and now they have leg and foot numbness. Would an EMG be appropriate in this situation, and would it tell us why that patient has numbness? It's possible. Like I said, this test focuses on large fiber nerves. And unfortunately, when you are doing surgery, you're cutting through the skin, which has nerves, small fiber nerves that I can't test. You are typically in a location where there are larger fiber nerves that the surgeons have to kind of move out of the way to get to where they need to go, and those nerves are at risk for injury. So if the numbness is coming from a large fiber nerve issue, then yes, the EMG would be helpful. If it's coming from a smaller fiber nerve, the EMG would at least tell us that the large nerves responsible for our motor function, moving the muscles, that they would be okay. So it's possible that the test would be helpful. This person states that they suffer from sciatic nerve pain occasionally, which is controlled by prednisone. At what point would they need surgery? It's hard to say. If your symptoms are well controlled with conservative means, you may never need surgery. The bigger question is what's causing the symptoms. Is it something structural? Is it something that is easily treated with physical therapy, medicines, maybe an injection? Have you failed all of those treatments and you're still having symptoms? So those all play a part into whether or not I get a surgeon involved in a patient's care. This question is about what to do if pain is worse with weather fluctuations, particularly this winter when 1 week we're in the single digits in the morning and then the next week it's 80 degrees. We do see a lot of patients whose symptoms wax and wane with the change in temperature. I think the best thing I can tell you, and what I tell all my patients, is the goal is to have you have more good days than bad days. And when we are trying to accomplish that goal, prevention is the key. So if you know your symptoms fluctuate with the weather and you know the weather is not going to be in your favor, that's when we really focus on making sure you're taking your medications as prescribed. You focus on doing your home exercise program to help mitigate some of the symptoms. Use a heat pad, an ice pack. There are things that we can do to help you get through those rough days, and that's really what we focus on. This question is about what exercises can you do to help with lower back pain and tailbone pain. There are so many great exercises out there, and it really depends on where your pain is coming from. As Dr. Parikh mentioned earlier, patients with spinal stenosis, we're focusing on exercises where you flex forward to open up that canal. And someone who may have a disc herniation, reaching forward is not your friend. We may have you do more extension-based exercises. So if you're interested in specifics, all of our offices have handouts of different exercises that we can provide you. Come in for an office visit. We can talk more about that. We also have a great team of physical therapists all over Charlotte and the surrounding areas who are happy to work with you and come up with a home exercise program for your specific problem. This question is asking about stem cell therapy, prolotherapy, PRP injections. That is the new trend in medicine. Currently at the Spine Center, we are not doing those treatment modalities yet. Really, there's not enough research behind it. So colleagues of ours around the country are working with these different treatment options to see if they work well for different injuries. Do they work better than what we already do? And what's the best way to deliver these treatments for patients? So as of right now, this isn't being done at OrthoCarolina Spine Center, but more to come if the research supports it. And then final question is, what about Botox injections? So that's a pretty broad question. Botox, as you may know, is a chemical that we inject into muscles to paralyze the muscle for about 3 months, sometimes a little bit longer. I personally don't use Botox in this setting. I have used it in the past for patients particularly who have had brain injuries, strokes, things where the brain and the nerves and the muscles aren't communicating well. You can develop what's called spasticity. So Botox is great for that. In an outpatient orthopedic setting, there's not a lot of uses for Botox, and I really don't see it being used very often for the issues that we're treating. But certainly if you have an issue with spasticity, there are physiatrists around Charlotte who do Botox for those issues. And if you wind up in my office, I can direct you to those individuals. Thank you.
So the last of the dedicated crowd. So I know there are some questions we didn't get to, and we definitely appreciate you guys being patient with us tonight. If we're going to be up here, if you want to come up and talk and ask us some questions, but obviously we'd also be happy to see you in the office. So thank you for coming tonight. It's been a pleasure.